Thank you everyone for joining us. As people file in, we will cover some housekeeping for today, but we are thrilled to have you all with us for Ethics Grand Rounds. We are going to go through some just housekeeping, as I said, and then we will move on to introduce our speakers and have what is going to be a truly engaging conversation today. Next slide. So if you have any questions, use the Q&A function and the center staff will respond to your question if you're having any technical difficulties. We are recording this and it'll be available on our website or through YouTube. We have enabled captions, so feel free to use those. And there are 3 ways to evaluate the session today. After the event, there will be a pop-up in your web browser that you can use to link to the evaluation. In addition, you will receive, there will be a presentations details document in the chat, which will have a link to the evaluation, as well as you will receive an email after this event to complete the evaluation. If you would like a certificate for CEUs, there will be a form in the presentation document, as well as IPE credit for university students, also available in the presentations document. For biomedical engineering students, there is a description of the requirements for you to receive credit. And to receive credit, you must attend at least 75% of today's webinar. So we are really pleased to be part of a community and a part of a community that is really dedicated to improving well-being. And we want to thank our co-sponsors, including the Center for Anti-Racism Research and Health Equity, the Center for Race, Indigeneity, Disability, Gender, and Sexuality Studies, the Department of Pediatrics, the Program in Health Disparities Research, Center for Global Health and Social Responsibility, the Rural Health Research Center, Business Advancement Center for Health in the Carlson School of Management, the College of Pharmacy, and the Schools of Medicine, Dentistry, Public Health, and Nursing. As I said, we all find power in community, and we are incredibly pleased to present today our 2 speakers. First, Monique Jindal is an assistant professor of internal medicine and pediatrics at Northwestern University and Lurie Children's Hospital. And Dr. Nate Chomilo is an adjunct assistant professor of pediatrics here at the University of Minnesota Medical School and the chair-elect of the section on minority health equity and inclusion with the American Academy of Pediatrics. I want to give our incredible speakers more than enough time today to share with you what they have to present as far as pediatric health inequities. We will take questions at the end, and at this point, I will turn it over to Dr. Jindal and Chomilo.
Good afternoon, everyone. Thank you so much for welcoming us into this space for our talk today. Where do we go from here? Eliminating racial and ethnic pediatric health disparities in 2025 and beyond. And before we get started, I just want to level set a bit. You know, as we were preparing this talk and thinking through what we wanted to say, I thought a lot about my own journey, my current struggles in this very difficult time, and the fact that while we do have a lot that we want to share with you today and want you to take in, we also want to hold space for the reality that none of us have all the answers. And this is a very difficult time, and that leaning on each other for collective action and healing is really of utmost importance right now. Next slide, please. We have no financial disclosures. The images that we are using in this presentation today are provided with permission or attributed or are open source. Next slide. We also would like to take some time for recognition of past trauma and abuse. We believe that it is important that we personally and professionally recognize the trauma, medical abuse, and discrimination that have happened to our Black, Indigenous, people of color, disability, and LGBTQ+ communities that have very rationally led to distrust in the medical field. Our work of equity and anti-racism requires that we acknowledge these many legacies of violence, displacement, migration, and settlement that bring us here today together, and we remain actively committed to rebuilding that trust with those who've had it violated the most. Next slide. Audre Lorde says, "When I dare to be powerful, to use my strength in the service of my vision, then it becomes less and less important whether I'm afraid. We're in a critical time in which we are all navigating confusion, fear, and uncertainty in the wake of recent unprecedented, chaotic, and deeply, deeply harmful actions and orders. And we've all watched our nation, our institutions, some of our leaders take varied approaches, whether that's complying in advance, erasing language from our institutions' websites, or staying the course. And I want to start this talk by encouraging us all to consider how our power, our strength, and our vision can combat our fears. And hopefully we can sit in that thought as we take in the messages and the shared experiences from our time together today. Next slide. As far as our objectives for you all, so we're hopeful that at the end of this webinar, you all will be able to describe policy levers within multiple sectors that influence racial and ethnic pediatric health inequities, communicate the role of healthcare professionals in advocating for policy change during this critical time, critically reflect on the ethical implications of prioritizing community over chaos and action over inaction, and advocate for policies that align with health justice and equity. Next slide. We also want to be sure that we start this conversation with some shared understanding of terms that we'll be using throughout the talk. So there are many definitions of racism, and today we're leaning on that of Dr. Kamara Jones. She describes racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. That unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And I really want to call attention to that last part, saps the strength of the whole society through the waste of human resources. A lot of what we're going to be talking about today is how the policies that are affecting our communities affect each one of us and how we are all interconnected. There are multiple levels of racism that Dr. Kamara Jones also describes in her work, and I really encourage you all to take a look at it if you haven't had the chance yet. But today we really focus on the level of structural racism. So structural racism refers to differential access to the goods, services, and opportunities within a society based on one's race. Dr. Jones uses the analogy of a gardener and their flowers. So I'm going to ask you all to bear with me and imagine this for a moment. Some of you may have heard this before, but imagine a gardener who has two flower boxes, one that she knows to be filled with rich, fertile soil, and another that she knows to be filled with poor, rocky soil. She has seeds for both red and pink flowers. And because she loves red flowers, she places the red ones in the rich, fertile soil. The red flowers, they grow up and they flourish, with the best of them growing tall and strong, and even the weakest making it to a moderate height. But in that box with the poor, rocky soil, the weak among them don't make it, and the strongest among them only grow to that moderate height. And as the gardener witnesses this year over year and continues to watch those red flowers flourish, she thinks to herself, wow, I was right all along to prefer those red flowers. This analogy can help us understand how structural racism operates. There is that initial historical insult of separating the seed into two different types of soil. The contemporary structural factors of the flower boxes themselves, which are keeping the soil separate and ensuring that those resources do not mix. And then the ultimate establishment of societal norms, of differential opportunity that leads to disparate outcomes, and that gardener is not only choosing an action in the face of need, but also leaning into those norms of biological determination and unearned privileges. Next, we want to bring you all to your attention to the idea of anti-racist policy. So that is any measure that produces or sustains racial equity between groups. Much of what we'll be spending our time today discussing is some of those policies. Next slide. Next slide, please. Thank you. When it comes to addressing structural racism's impact via policy, we must acknowledge some of the well-documented limitations. So to aid in this, our talk will reflect on Dr. Martin Luther King Jr.'s book, Where Do We Go From Here? Dr. King wrote this throughout 1966 and early 1967, reflecting on the state of the country and the movement for civil rights after the historic passage of the 1965 Voting Rights Act, the 1965 Watts riots, and the white backlash in his time living in Chicago in 1966. This first chapter is titled, Where Are We? And in it, Dr. King reflected on how many in America believe that the work of justice stops once a bill is signed into law, noting, overwhelmingly, America is still struggling with irresolution and contradictions. It has been sincere and even ardent in welcoming some change. but too quickly, apathy and disinterest rise to the surface when the next logical steps are to be taken. Laws are passed in a crisis mood, but no substantial fervor survives the formal signing of legislation. The recording of the law in itself is treated as the reality of the reform. Next slide. While we are clear-eyed that laws and policies themselves can't bring about justice alone, they are a critical component of necessary change. So this is one example of a framework that centers the idea that structural racism influences our laws and policies within the systems that children are born, develop, and go on to raise their own children. These laws and policies perpetuate inequities in resource allocation and opportunity within several sectors, that being housing, employment, the criminal legal system, and immigration policy. And that in turn produces the racial and ethnic health inequities, which can have lasting impacts across generations. Next slide. Research shows that about 70% of health and well-being is derived from factors outside of the healthcare system, often what we call social determinants or social drivers of health. These are the conditions in which people are born, grow, work, live, and age. And about only 10% is based on the health system itself. This really highlights the importance of addressing these factors in order to achieve health equity. In democratic societies such as the US, social policies and resource allocation are based on the decisions made by our freely elected leaders. And so therefore, health equity and politics cannot be disentangled. Next slide. The racial inequities that persist amongst our nation's children are very well documented. And unfortunately, the current climate places us in a position in which those inequities are at risk for worsening, and the gaps that we already know to exist are likely to widen. Next slide. This diagram from the National Equity Project captures how policy efforts that do not directly address how structural racism impacts children, adolescents, and their adult caregivers will not achieve equity and instead will worsen gaps and existing disparities in access and quality. I'll spend the next part of the talk discussing key components of housing, employment, and economic opportunity, criminal, legal, and immigration policy in the context of structural racism. Next slide. So beginning with housing and child health, the link between the two is very well documented as well. So when we think about this, we can think about the different facets of housing. So housing instability, this can look like moving frequently or being unable to pay your rent, falling behind. That has been associated with depression, drug use, and unintended pregnancy. Poor quality housing, which includes a myriad of factors, but some are poor ventilation, overcrowding, dampness in the home, has been associated with asthma, poor cognition, and emotional focusing. Unaffordable housing leaves families with less disposable income to promote their child's development. And then location. Of course, we know that where we live determines our access to resources such as high quality education, healthy nutrition, and the quality of healthcare. Next slide. Housing disparities are driven by policies rooted in structural racism. So redlining is often called upon in these discussions. That refers to the systematic denial of mortgages in predominantly minoritized communities in the early 1900s. However, the issue is far more present day. The zoning of these areas that experience disinvestment remain largely unchanged and shape access to opportunity today. Many of the policies that we see are responsible for the continued chronic disinvestment of these communities and ultimately limited home ownership, limited access to high quality housing amongst minoritized communities, and ultimately those have the health impacts that I described before. I'll highlight a few of these policies that act against the structural forces and that perpetuate the racial inequities. Next slide. There are new laws in both Illinois and Minnesota that prohibit landlords from retaliating against tenants who report code violations, seek repairs, or engage in tenant organizing. They allow tenants to create associations to improve their living conditions, amenities, and their community life. And it also prohibits landlords from retaliating against anyone in a tenant organization, from increasing their rent, decreasing services, or altering any existing agreements. So some of these tenant protections are really crucial. Another lever is thinking about our need to increase the stock of affordable housing. One way to do this is through land use reforms and addressing some of the exclusionary local zoning regulations that are in existence. So this can look like allowing multi-unit family housing to be built in areas that prohibited this prior. This can look like decreasing the minimum lot size or getting rid of parking requirements. And research has shown that these approaches are associated with reduced displacement risk and increased racial diversity in those communities. Next slide. And while we don't have time to get into the many other policies that address housing inequities, I do think it's important to be aware that there are many other local levers to pull on. So, for example, funding for fair housing testing to limit discrimination in the home search process is very important. And as you can see here, that has been threatened very recently at the state level. And community investment initiatives such as the new market tax credits, which actually give a 39% tax credit to private investors moving into low-income communities, have been shown to be really beneficial. This was something that the Red Lake Band of Chippewa in Minnesota was able to utilize to fuel development within their community. Next slide. Moving on to economic and employment opportunities and child health. The median annual household income for Black homes is about $45,000 compared to $76,000 for white households. Low parental socioeconomic status is associated with low birth weight, asthma, depression, and antisocial behavior. Next slide. When we think about the options for anti-racist reform within this sector, it is really important to consider how safety net programs operate. So safety net programs such as SNAP, the Supplemental Nutrition Assistance Program, and TANF, which is the Temporary Assistance for Needy Families, have very clear benefits that are well researched. However, many of their policies are rooted in racism. Today, we're going to focus on the importance of banning work requirements for safety net programs. And before we get into the nitty-gritty of that, just conceptually, I want to say that a focus on mandatory work requirements reinforces racist stereotypes that parents that are receiving assistance who are disproportionately people of color do not work, do not wish to work, and will only do so if coerced. Additionally, further work requirements focus on getting recipients into jobs as quickly as possible, and this actually fuels occupational segregation, keeping Black people stuck in low-paying jobs in sectors such as food service and childcare. This can result in families working in low-paying sectors continuously earning too little to actually lift their families out of poverty. Next slide. But really, the most important point is that these requirements do not work. So first and foremost, they do not increase employment because most people are already working. An example of this is in Arkansas, an experience in 2018 to 2019 in which Medicaid work and reporting requirements with consequences for noncompliance were instituted. Researchers found that work and reporting requirements were associated with losses in coverage, an increase in a percentage of adults who were uninsured, and no significant change in employment, as nearly everyone that the policy was targeting was either already working or had qualified for an exemption. The Congressional Budget Office did a report in 2022 that noted that there were high rates of employment both within SNAP and Medicaid, leaving very little room to increase those rates further. And then in 2023, another analysis was done and showed that a nationwide application of this policy would actually increase the number of people without insurance and would not increase employment. Secondly, these programs cost a lot of money to the state. So Arkansas's costs were greater than $26 million. Georgia's Medicaid work requirement program has cost them over $57 million, most of which was spent on administration rather than medical services. And then Kentucky has estimated that its program would cost them $270 million. Next, they're very confusing. There's no medical diagnosis for able-bodied. So you may know that this work requirement is for people referred to as able-bodied adults without dependents. Also, they're very confusing, and the vast majority of enrollees lose coverage because of their lack of awareness. More than 18,000 people lost coverage, or about 25% of the population, simply due to the failure of not regularly reporting their work status or documenting their eligibility for exemption. And then lastly, they weaken our community. So in Arkansas, disenrollment was associated with poor medication adherence, delays in care, and medical debt. Next slide. This is also an issue when we think about TANF, Temporary Assistance for Needy Families. So the map on this slide shows that most states take away the entire family's benefits for non-compliance with work requirements. There's also very real racial disparities here. So Black people receiving TANF are significantly more likely to be sanctioned than white recipients are. Black and Indigenous families are far likelier than other families to be cut off due to time limit changes. Black people face disproportionate barriers in the labor force at baseline, and research finds that all else equal, states that have larger Black populations have more restrictive TANF policies. Next slide. And again, while we don't have time to go into the many other facets that impact economic opportunity, I want us all to be aware that there are other levers, again, to lean on at the local level. So access to paid family and sick leave has been shown to improve well-child visits, dental care, influenza vaccination, and breastfeeding rates. And it's an issue that is currently being dealt with at the state level, as you can see here. This is actually a photo of an op-ed that Dr. Chomilo wrote in 2019 supporting paid medical leave in Minnesota, framing it through the circumstances of his own family. This passed in Minnesota in 2023, but there was more than a decade of advocacy that led to its passage when the state's resources, the political leadership, and the political will aligned, really highlighting that this work is a long, long journey. Next. Now pivoting towards the criminal legal system and child health. Racial and ethnic disparities are present in every step of the criminal legal process and are linked to adverse health in several ways. So a third of Black men are imprisoned in their lifetime. 1 in 1,000 Black men will be killed by police. Half of Black women have a loved one who is incarcerated, and 1 in 9 Black children have a parent who is currently incarcerated. And the health impacts of this are striking. First, disproportionate police contact is associated with poor mental health, risky sexual behaviors, substance use, and heightened mortality risk into adulthood. Youth detention and incarceration is also associated with worse health outcomes. And lastly, incarceration influences the health and well-being of adolescents, even when they are not the individuals that are being incarcerated. Next slide. When we consider anti-racist policies, we want to highlight the importance of, excuse me, reforming parental incarceration policies that will ultimately increase parent-child contact and connectedness. So research demonstrates that young people with incarcerated loved ones experience feelings of alienation, adverse mental and physical health, and often forego health care. Next slide. So an innovative policy that I wanted to highlight, Minnesota lawmakers passed the Healthy Start Act in 2021, and it's believed to be the first state to allow some mothers to live outside of prison with their new babies. In most places, a woman who gives birth in jail or prison is separated from her baby within hours or days. And so this innovative policy is preventing that separation from happening at a very critical time of development. Next slide. We can also consider how to interrupt the school to prison pipeline. On the left is a map that shows the rate at which Black girls are arrested compared to white girls in schools, with the darker shades of purple indicating wider disparities. Students of color are more likely to go to a school with a law enforcement officer, more likely to be referred to law enforcement, and more likely to be arrested at school. Research demonstrates that students who attend schools with high percentages of Black students and students from low-income families are more likely to face security measures such as metal detectors, random contraband sweeps, security guards, and security cameras, even when you control for the level of misconduct in the schools or the violence in those neighborhoods. No data indicates that police in schools improve student safety, student educational outcomes, or student mental health. In fact, there is some data that suggests that having school resource officers or police officers present in school actually harms youth. But the benefits of investing in mental health services are very clear. So the map on the right shows states which meet the recommended student to counselor ratio, which you can see is almost no states. 1.7 million students are in schools with police but no counselors. And schools that have mental health services have seen improved attendance rates, better academic achievement, higher graduation rates, lower rates of suspension and expulsion, and other disciplinary incidents. Next slide. Other anti-racist policies that we won't really elaborate on much today, but I just want to point out is that we can adopt state and federal minimum age laws to protect children younger than 14 years from arrest and prosecution and from being placed in adult prisons. We can promote diversion and decarceration of young people with low-level offenses. We can support healthy conditions of confinement to promote healing, so that can mean banning solitary confinement for young people, improving access to quality mental health care. and ensure robust reentry support at release for parents and young people that are returning to communities. So often people lose their Medicaid coverage as they're going in and out of the system, and then also ensuring that we provide access to vocational and educational support. Next slide. Lastly, I'm going to discuss immigration and child health. So some of this is pretty simple in that exclusionary policies are associated with poor self-rated health and poor mental health, and inclusive policies are associated with better child health. That can look like amendments to eligibility restrictions for food assistance and CHIP, the DACA program, or even advocating for driver's license for undocumented immigrants. And some of the health impacts that we have seen through that are improvement in food security, decreased anxiety, improved asthma control, and ensuring that children have a usual source of care. Next slide. We're in very difficult times when it comes to immigrants' health and well-being. And so I think sometimes it can seem really scary and that there aren't really ways for us to act. But again, there are local levers for anti-racist policy. So states can limit ICE's access to essential spaces such as schools, churches, and hospitals. States can track and monitor deportation and detention actions and document the abuses that occur, such as illegal stops. City councils can erect a firewall between state and local resources and federal immigration enforcement. Governors can issue pardons to immigrants for state criminal convictions that might make them deportable. States can increase visa certifications for victims of certain crimes. States can also fund legal representation for immigrants that are facing deportation. And then we can also support local movements that are against new detention sites and the leasing of county jail space to ICE. I'm going to turn it over to Dr. Chomilo.
All right, thank you, Dr. Jindal. So I'm going to jump in by highlighting the last domain we'll review today from our Lancet paper, health insurance and child health. Although we acknowledge that health is about much more than health care, health insurance coverage plays a critical role in access to care and reducing racial, ethnic health disparities for children. On the right, we see data from KFFF that shows among households in 2023 with children 0 to 17, those that did not have health insurance and were uninsured were nearly 7 times more likely to report not seeing a doctor or health professional, or that they did not have a usual source of care. The connection to health insurance and economic opportunity is also notable, as cost was significantly more likely a barrier to those without health insurance. Conversely, studies have shown that children covered by Medicaid miss less school, do better in school, graduate and attend college, become healthier adults, earn higher wages, and pay more in taxes compared to those who are uninsured, making Medicaid a key policy in delivering child health equity. Medicaid covers about 20% of all Americans, but almost half of children. And children, in fact, are the largest enrolled group by eligibility category in the nation. And as you note on the left there, the impact of Medicaid differs across our communities as they are defined by race and ethnicity, with over 58% of our Black children covered by Medicaid, over 53% of our Hispanic children covered by Medicaid, and nearly 60% of our American Indian and Alaskan Native children covered by Medicaid. Additionally, Medicaid covers 40 to 50% of births across our country, and the breakdowns by race ethnicity for births are also similar. So given Medicaid's role in health insurance coverage for communities disadvantaged by structural racism, there were several policies we believed would help decrease child health disparities. We noted research that detailed stark differences in child health between states that chose to expand Medicaid under the Affordable Care Act compared to non-expansion states, with expansion states displaying population level improvement in prenatal and maternal health, higher preventative care use, decreased incidence in child neglect, decreases in high school dropout rates, and a nearly 50% greater reduction in infant mortality. And of note, after Medicaid expansion, the sharpest decline in infant mortality was among Black infants. We also note that low reimbursement rates for Medicaid is a particular challenge for pediatric healthcare, since so many clinics have the majority of our patients on Medicaid. We found evidence that relatively small increases, one study cited just $10 per visit, could improve access for Medicaid enrollees, and was even linked to a reduction in school absences for primary school-aged enrollees. The map on the right is from Georgetown's Center for Children and Families, and it shows states that have implemented or are developing multi-year continuous eligibility for children, particularly in the first 6 years in life. This is a policy that combines what we know about the crucial period of development in those first 5 years, what we have known about churn, that eligible children are more likely to lose their coverage due to paperwork errors, and then miss out on important care. And then what we learned during COVID-19's continuous eligibility during the public health emergency that helped keep everyone covered. So continue to evaluate the implementation of the multi-year continuous eligibility for children that almost a dozen states are now either implementing or applying is going to be crucial in the coming years. Then lastly, Medicaid has been innovatively utilized to address many of the social determinants of health. And the map on the bottom is from KFF that shows states that have implemented Medicaid waivers that cover health-related social needs. Unfortunately, last month, the Trump administration rescinded the guidance that the Biden administration had issued to states on how to consider covering HRSNs. So the long-term fate of this lever remains uncertain. Ultimately, when you think about everything that Dr. Jindal just shared, and the impact of health insurance, the cost of not addressing child health disparities will fall on us all. Last year, the National Academies of Science, Engineering, and Medicine published a consensus study, a report titled Launching Lifelong Health. I was fortunate to be on the authoring committee for this report. And one of the ways we made the case for investment in children is what we called our shared societal gains. And so looking at how protecting the future workforce for economic productivity and national security is a shared societal gain, upholding national values and the moral imperative to nurture healthy young minds and bodies, leveraging the prevention of a potential in leveraging the prevention potential in emerging science, supporting future child bearers in a time of declining birth rates, ensuring the health of future caretakers for a growing retired population, protecting the workforce productivity of parents, and addressing early antecedents to adult disease now can pay off later. However, as the Urban Institute found in their social genome model, designed to help identify and assess which policy interventions might most effectively and efficiently break that pattern of intergenerational disadvantage, Black and Latinx children are currently less likely than white children to be on track for healthy development. And so depending on your data source, children under 18 in the US are already majority minoritized or will be by the 2030 census. But we are already starting to experience the consequences of a lack of investment in children, as we noted in the Launching Lifelong Health report, that in 2023, for the first time, 3 branches of the military didn't meet their enrollment goals due to 77% of youth not meeting criteria due to health conditions like mental health, obesity, or substance use disorders. So where do we go from here? I will transition us now back to the reflection that Dr. Jindal started us on using Dr. King's book. One key observation Dr. King shared was the phenomenon of white backlash that ensued after the initial successes of the civil rights movement. As he noted, a year after the passage of the 1965 Voting Rights Act, the white backlash had become an emotional electoral issue in California, Maryland, and elsewhere. In several southern states, men long regarded as political clowns had become governors or only narrowly missed election, their magic achieved with a witch's brew of bigotry, prejudice, half-truths, and whole lies. This is one of the many passages in the book that we can pick right out of 1966 and 67 and place in the last 4 years between 2021 and 2025. But what I leave with every time I sit with this work is a deep appreciation for the hope that Dr. King continually espouses, although he had experienced a great deal of personal dehumanization and had the awareness of the limitations of what he called white moderates as true allies, he remained hopeful. But that hope wasn't blind. It was grounded in an ability to speak the truth and call people to action. And so my simple distillation is that inaction is submitting to chaos, and action is finding or creating community. And as he noted, if America is to respond creatively to the challenge, many individuals, groups, and agencies must rise above the hypocrisies of the past and begin to take immediate and determined part in changing the face of the nation. To further reflect then on how we move to action, let's examine our current system through some of the core principles of biomedical ethics and the wisdom of Dr. King's words. So thinking of non-maleficence, or the principle that medicine and its systems should do no intentional harm, it calls us to question what laws and systems are perpetuating harm. In his work, Dr. King notes that poverty is one of the, if not the main reason for the most inequalities we see, including health. He notes that the curse of poverty has no justification in our age, that it is as socially cruel and blind as the practice of cannibalism at the dawn of civilization, and that although there have been multitudes of programs to address poverty, they're all fragmented, periodic, or short-lived reforms. And so our failure to conceive and invest in a total, coordinated, and fully adequate program to end poverty, therefore, is an act of maleficence. Beneficence is the principle of doing good for others. Within this principle, we can then ask, what are policies that bring us together? Dr. King noted that most all programs to end poverty were not only fragmented, periodic, or short-lived, but they were indirect. They aimed to address poverty indirectly by solving other things first, like housing support or food support. And the core of beneficence is, as it relates to child health, should therefore be answering the question, what policies actively support child and family well-being? In 2021, the United States experienced a significant reduction in child poverty rates across communities, as you see on the graph on the right there from the Census Bureau. With significant reductions in racial disparities largely due to policies implemented through the American Rescue Plan Act. Policies like increasing the credit amount, so the child tax credit was raised from $2,000 per child to $3,600 per child for those under 6 and $3,000 for children 6 to 17. Eligible families could receive half of their credit through monthly payments from July to December in 2021, providing more timely financial supports through those advanced payments. There was direct stimulus payments of $1,400 per person, providing immediate financial relief. And then there was extended and enhanced unemployment to support those who lost jobs during the pandemic. This brief window really laid bare the reality that in the US, beneficence is possible when it comes to eliminating child poverty. It is political will and popular demand that is required. Justice encapsulates both fair and balanced distribution of resources and of protections. And so we must therefore ask, are we distributing our health resources, the social drivers of health and healthcare, and our protections under law to help ensure equal opportunity for health fairly? Dr. King's answer was frankly that we weren't. Notably, it's not because we are comfortable with inequality, it's because, as he noted, we are not yet willing to pay the price to eradicate it. In other words, while we talk about and take oaths that commit us to non-maleficence, beneficence, and justice, we aren't yet fully and truly committed to these principles. To get there, we must ask ourselves hard questions like, will we cede wealth and power accumulated over decades to those who have been excluded? Will we engage in meaningful dialogue designed to break down our barriers, engage in authentic relationships, and learn of our shared humanity? And can we use our power to create more just systems that ensure that opportunity is equally distributed? You may have noticed a lot of we statements, and that's because I believe that the path to healing our healthcare system really lies in community and authentic solidarity. So we'll wrap up our time reflecting on what community and authentic solidarity can look like. For those four pillars of medical bioethics enthusiasts, I did not forget about autonomy, the right of individuals to make informed decisions. However, when looking to make system change, autonomy also needs to be looked at through the lens of communities, particularly those that have been disadvantaged or marginalized. As Dr. King noted, we must utilize the community action groups and training centers now to create more, not merely an electorate, but a conscious, alert, and informed people who know their direction and whose collective wisdom and vitality commands respect. One strategy that's been employed to shift more autonomy to communities in creating the conditions for their health is to have healthcare institutions become anchor institutions. This was first described by the Aspen Institute way back in 2001, initially centering on the community building potential of universities. It's since been adapted to create a broader place-based means to build community health and wealth. And there was this piece in the 2023 in the New England Journal of Medicine that highlighted Rush University's approach in Chicago. They came to the approach after reflecting on this map on the right that shows a 16-year gap in life expectancy between neighborhoods surrounding their institution. And so they did a community health needs assessment that ID'd structural racism and economic deprivation as the driving forces. And then they started talking to their own employees who lived in those neighborhoods. They described them as their first community and centered them in their development of interventions. And then the next year, they brought other health systems along to create West Side United, a combination of 5 healthcare systems in the area. And because of this trust that they built in 2020, when the pandemic hit, they were selected to lead Chicago's COVID-19 racial equity response team. And overall, they've been able to guide millions of reinvestment in their local community and change the relationship their own employees have with their institution and surrounding communities. And one example from their anchor strategy is the Sankofa Wellness Village. Sankofa is Ghanaian for go back and get it. There's currently 4 anchor projects being launched: Sankofa Wellness Center, which is a community health center, a center for arts and activism, a social innovation hub for small businesses and entrepreneurs, and a community grocery initiative that helps new growers and expanding options. And so to me, this is a wonderful illustration of how health systems can be in community and live out the principles of autonomy, non-maleficence, beneficence, and justice. And as El-Haj Malik Al-Shabazz, better known as Malcolm X, noted, when I is replaced with we, even illness becomes wellness. And so solidarity within and between communities is crucial to affect change. As Dr. King noted, solidarity is therefore both simple and complex. I have been on a personal journey and professional journey over the last 20 months to better understand what it means, and have found it to be a term that is thrown around a lot, much like health equity. You ask 10 people for a definition, you'll get 10 different definitions of what solidarity means. I personally like author and activist Adrienne Marie Brown's description of solidarity as an invitation to flock, staying separate enough to not crowd each other, aligned enough to maintain a shared direction, and cohesive enough to always move towards each other. With that in mind, we must recognize where we have and have not shown up in solidarity, as trust is critical for authentic solidarity, and it can't be taken at face value. It must be shown. So I'll ask us all to do a little reflection activity virtually here to check in on our own understanding and expression of solidarity. So either by raising your Zoom hand or just reflecting on your own, present a show of hands. Who here knows all of the answers to ending the epidemic of gun violence in the United States? An epidemic that is the leading cause of death for children and youth, and a key child racial health disparity. And so now then, show of hands, who has advocated that we should take common sense measures to make weapons of mass murder less available? Now, show of hands, who here knows the exact policies to solve the challenges of immigration, particularly at our southern border? And similarly, show of hands, who spoke up when they saw families forcibly separated and children held in cages, or when ICE started raiding workplaces and laying wait outside of schools? And show of hands, who has figured out the conflict in Palestine? And show of hands, who, after seeing schools and hospitals decimated, refugee camps incinerated, children mutilated, and families permanently separated, has spoken up about our government's ongoing and unconditional funding of weapons used in acts that have been thoroughly found to be consistent with genocide whether Amnesty International, the United Nations, the U.S. Center for Constitutional Rights, or the International Court of Justice, the evidence is clearly in front of us and has been for well over a year now. In January of this year, at the time of the brief ceasefire, UN agencies estimated more than 13,000 children had been killed, 25,000 injured, creating the largest cohort of pediatric amputees in known history, and another 25,000 hospitalized from malnutrition in what's left of Gaza's health care infrastructure. Since then, another 1,000 children are feared dead since Israel broke the ceasefire agreement. Some have spoken up about how we as public health and medical establishments are feeling again, pleading that folks leverage their personal and institutional power to call attention to the atrocities being committed against Palestinians with our tax dollars and without accountability, but not nearly enough. Like just about everyone else here, I don't have all the answers, but I know the first step is we must do all we can to stop unnecessary and preventable suffering. Our shared code is supposed to include those principles of non-maleficence and beneficence. We therefore must see ourselves, our communities, our children, wherever we see injustice, whether that be in Palestine or North Minneapolis, Bemidji or the Sudan, or our community members who simply seek to live their full lives, identities, and abilities and loves. If we fail to see ourselves and those with and without power, then we are all at risk. Our professions, public health and healthcare, risk further erosion of trust as we ignore the facts and evidence of harm right in front of our eyes and fail to do anything. In the Twin Cities, there are over 2,000 Palestinians, many with immediate family members in Gaza who have heard little or nothing from our Minnesota institutions and leaders. And by our silence, we also collectively risk normalization of mass suffering and death. This is something that I was reminded of last year when I traveled to the National Memorial for Peace and Justice that Brian Stevenson's Equal Justice Initiative has created in Montgomery, Alabama, to memorialize the generations who endured racial terror at the silence of many in our not too distant past. To build that trust means we must move beyond words to actions, as Palestinian Dr. Ali Tawari has shared. And so the quote, "First they came for," has been part of the permanent exhibition at the United States Holocaust Memorial Museum since its opening in 1993, coming from a minister that expressed his belief that Germans had been complicit through their silence in the Nazi imprisonment, persecution, and murder of millions of people. He felt this was especially true of leaders of faith-based organizations. And those who have been paying attention and engaged in the larger movements for social justice are rightly worried about what has been happening and how this is directly connected to what we are seeing in 2025. The first they came for Black Lives Matter protesters, no Dakota Access Pipeline organizers, protesters against the genocide in Gaza, and then they came for my NIH and CDC funding. And so notably, the connection between our silence about the US funding of wars and conflicts in other countries and our inability to eradicate child poverty here in the US has led to our current debate about our country's allocation of its vast resources. Dr. King warned us about the three evils of racism, materialism, and militarism through attacks on civil rights and cuts to programs and offices that uphold them. We see racism is alive and well in our budget. Taking money from children, our elderly, those in poverty to give tax cuts, the wealthy, shows us that materialism still has a grip on our culture and political ideology, and an unwillingness to even entertain or advocate for cuts or restraints on military spending. A budget that is some $189 billion more than we spend on Medicaid means we are left to defend one of the most successful child health policies we have from draconian cuts in the name of militarism. So where we've been, however, does not mean we cannot get where we want to go. It just may take a little longer. One of the stories Dr. King shares in this book as he reflects on the challenges he was facing in 1966 and 67 was about a conversation he had with a pilot going from New York to London. On the way to London, it took 9 hours. On the way back, it took 12 hours. And so he was asking the pilot why. And the pilot was saying, well, on the way to New York or on the way to London, we have a tailwind. And on the way back, we have a headwind. And so he reflected that in any social revolution, there are times when the tailwinds of triumph and fulfillment favor us, and other times when strong headwinds and disappointment, setbacks beat against us relentlessly. And his reassurance was what he heard from the pilot is the engines are strong enough to get us there. It will just take a little bit more time. And that is his reassurance as well. We must not permit adverse winds to overwhelm us as we journey across life's mighty Atlantic. So as we close, it's important to reflect on Dr. King's words that tomorrow is today and on the urgency of now. Two examples of the urgency of now come from a piece that Eric Reinhardt, a political anthropologist, social psychiatrist, and psychoanalytic clinician, wrote in STAT that does a wonderful job capturing how we must be prepared to make decisions and act differently if we are to avoid repeats of some of our darkest days. As healers, we really need to think about becoming not collaborators, but resistors in our positions. And then my friend and fellow National Academy's Report committee member, Hala Dura, is a Palestinian-American woman, mother, daughter, and cousin who's lost more than 100 family members to Israel's genocidal acts. And she has channeled what she has experienced over the last 18 months to found a collaborative, the Humanization Matters Collaborative, that is focusing on the critical role of humanization as we imagine a brighter future. And I often think that if Hala can take her pain and channel it into a brighter future for me and my kids, then I have no excuse to not do what I can as well. To help you in your movement to action, here are several steps that you can take along a continuum that help move us towards justice: educate, advocate, organize, activate, support. The most important thing is that you start to continue doing something and as able, and add another type of effort that will bring you closer to solidarity where you can, when you can. So we'll end with just some questions to share for folks to reflect your own awareness and where you're at on your journey. And it's notable that today marks 57 years since Dr. King was assassinated. And so what would it look like for the next generation of children if your daily work was a direct contribution to building Dr. King's vision of community? And with that, I'll pass it to Dr. Nino Suarez. And thank you all for your time and your questions.
Thank you so much, Dr. Jindal and Dr. Chomilo. This is a really powerful talk that allowed us to really understand the depth of what we're talking about, and seemingly somewhat overwhelming to those on the ground wanting to affect the policy sphere. So really appreciate your highlighting those things. We have a couple of questions that I'd like to put out first, and then we can kind of see where they lead. But there was a question that what should or might reparations in medicine and pediatrics look like today? This may be in contrast to affirmative action to ensure fairness and equity in current conditions, and not admitting or repairing accounting for prior harms and violence. Should we argue from an act from one posture or the other, or do you have a particular thought about that?
I can start. I think it's a really important piece to think about reparations in the framework of healthcare and medicine. And there are a few ways that I think we've started to do it, but we probably need to put a lot more emphasis behind it. So, of course, admitting to the many harms that our field has committed and continues to commit, I think is a first step. And then thinking about the race-based algorithms that are still in use. So that is one way to really actively dismantle some of the racism that is prevalent in our field. And then I think to your point about affirmative action, yeah, I think one thing that reparations could look like is how we think about funding tuition for Black and Brown students in the medical field to increase the diversity of our workforce. But I'll pass it over to Dr. Chomilo for any other thoughts.
Yeah, I think there's a lot of debates on reparations, and when you start talking about it, you start wanting to know, are we talking about African descendants of slavery or folks that have been here for several generations? Or and so there's some complexity there that I'm not equipped to address. But what I would say is I think there are some kind of broad policies, particularly when you look at children and the fact that our community of children is diversifying and it's going to be majority minoritized, that if we do universal policies for children, that there will be an aspect of kind of racial equity and justice within those. And so that's one of the things we were looking forward to doing with the continuous eligibility for those first 6 years on Medicaid, for example. And so I think there's a lot of policies that if we took a universal approach and not required certain things that would have over time some effect of reparations. But again, there's folks that have really strong opinions on that as well. I can't hear you, Dr. Neil Suarez.
I apologize. Someone asked about increased reliance on AI in healthcare and kind of your perspectives on how that may impact this problem you're addressing right now.
Yeah, I'll start in that, there's already, AI is kind of a broad term, artificial intelligence, usually talking about, large language-based models. There's a lot of, particularly on the health insurance side, right, organizations that have already been using algorithms to determine things like whether or not different claims go through or not. And so there's been an existence of this already. There's been some research already that shows that there's some racial bias encoded into some of those algorithms. One in particular that was actually intended to try to help folks from with poor healthcare outcomes, but disadvantaged Black individuals because it looked at utilization as a way to kind of identify folks and give them more resources. And there's lots of data out there on the number of barriers that folks from our Black and brown communities face in accessing care. And so their utilization is going to be lower, so they're not going to get more resources. And so then the gap widens, right? And so there needs to be a lot of intention to any innovation that's put forth, including AI. And so far there's been some conversation, but there's a lot of concern, I think, that there's not enough yet.
So as someone who's relatively new in their journey in health equity and advocacy, someone's asking what recommendations you have for using their voices in times when it feels difficult because of federal action.
I can start off. I mean, I think our collaboration on this talk today is a good example of what I'd recommend. So Dr. Chomilo is a role model for me and someone that I lean on, especially during these difficult times. And so I think when you're newer and younger in your journey, it can feel scary and you have strong convictions and you don't know what to do with them. And I think kind of the way we try to talk about leaning on the past and the wisdom of the people before us, think about that within your circles as well, and gain courage and guidance from them.
Yeah, and I'll share, I the last, 5-6 years have been hard. I've entered therapy for a number of reasons. And one thing that my therapist actually shared with me is, some of this sitting with the text, like Dr. King's text, you're being in community with your elders. That's a way of kind of, starting community. And for folks who have different, comfortability and engaging, starting with the wisdom of our elders that they left behind is a good place to start. The intergenerational nature. So not only just looking at folks who are elders or who have transition, but I've learned a lot from medical students, trainees as well along the way. And so being open to kind of learning from folks across generational lines is a really great way to kind of expand and understand things differently, different perspectives. And just start entering spaces, asking questions. And then thinking about what are the actions you can do. I think one of the things that I've always tried to do, I've learned from others, is when I see an issue, not just to think that the job is to raise the issue and stop there, but then let's think together, how can we solve it? One of the reflections that Dr. King talks about is, that we don't celebrate small wins enough, and that we think that if we don't get everything that we want right away, that what's the point of even trying, versus understanding that the way we get to liberation, the way we get to the world that we view for all of us is through a series of small wins. And so being comfortable celebrating those, and then kind of getting back together and continuing to work.
Just one thing I'll add to that is, in conjunction with that is, and something that Dr. Chomilo actually encouraged me to do was, the chaos is the point, right? We're feeling overwhelmed and we're feeling helpless. And like, how could we possibly do anything? But choosing one thing and working on that one thing that you're passionate about is a start, and it's going in the right direction.
Thank you both so much. I think the big message here is that this is a like-minded, in many ways, community interested in really promoting the health and well-being of children, and that the we part we should find strength in. And I really just appreciate your time and your participation, and thank you to the audience for engaging with questions. We will just move on to just a final couple details to share that we have 2 upcoming webinars for ethics grand rounds. Next will be Kelsey Berry. Thank you, Andrea. Talking about whose job is it to manage social determinants of health within a hospital space. And then in May, we'll have Brendan Parent, who's talking about organ donation and donation after cardiac death. And then in August, we will have a talk about medicine's definition and role in suffering. So we appreciate very much all of your attendance. Please know that we have 3 classes through the Center for Bioethics coming in the fall. Feel free to reach out to the center if you have any questions about those. And we will see you at the very next Ethics Grand Rounds with Dr. Berry. So thank you very much for everyone who attended and participated. And thank you again very much, Drs. Chomilo and Jindal. Much appreciated.